Dude, can I start or should I wait? Dwaragesh, dude. Guys, let's start in about 2 minutes time. Okay, guys, let's start. Because it's a common discussion, I'm going to do it in English. But if there's any problem, just ask. I'll clarify it. Okay. And I hope you all can hear me. Can you all hear me? Hi. I just take that as a yes then. And I hope you can see the screen. Okay. So today's the WAP was on the endocrine and neurology modules, right? So here there are a bit of a problems with the answer scheme, but we'll correct them along the way. Okay. So the first one is about renal cell carcinomas. So here, out of the three renal cell carcinomas, which that we know, actually four: clear cell carcinoma, papillary carcinoma, chromophobe, and collecting duct carcinoma. We are talking about the clear cell carcinoma. Okay. So here, I'll just, I won't be reading out the exact answer because that you can do anywhere. I'll just stress on the important points that you need to remember when writing a similar answer anywhere. Okay. So when we are talking about renal cell carcinoma, in any answer, it's important to write how to differentiate it from other type of renal carcinomas, right? So all these renal cell carcinomas, they will occur in the cortex. So whenever you're asked to describe the macroscopy of a renal cell carcinoma, always state that they occur in the cortex. And to differentiate the three types that we're talking about mostly, which is the clear cell carcinoma, the papillary carcinoma, and the chromophobe carcinoma. In the clear cell carcinoma, it's usually just one mass and it's yellow to orange. And it's usually well circumscribed because it's pushing the remainder of the kidney to one side. It's pushing the tissues and it's occupying the area. So it's usually well demarcated. And then when we take papillary carcinomas, they are not unifollicular, they are usually multilocular. Okay, that means they pop up in various locations. And when we take chromophobe carcinomas, they are usually gray and they are also unilocular. That means there's only one. Okay, so this is chromophobe, this is papillary, and this is clear cell. So out of these things, the clear cell carcinoma is usually what we are questioned on the most. So in this, whenever you're describing it, remember to say that it has a, one of the most important things is it has a variegated appearance. Okay, variegated means like a tinfoil sheet, kind of like this. So it's not a flat cut surface, and the color is usually yellow to orange. And for any of these things, you remember to say that there's small foci of hemorrhage and necrosis because it's a malignant tumor. So even if you forget everything else, if you say these things, you have a multitude of the marks. See, and I forgot one more important thing. The other thing is in clear cell carcinomas, except for the main lesions, sometimes a few satellite lesions can also be present. That's also an important point because you can't see this person has undergone a radical nephrectomy, right? That means the entire kidney has been removed. So the kidney will not be removed if you can just take the tumor out. But here, because of the satellite lesions, we can't do that. So the presence of satellite lesions is also an important point here. Okay. Right. Now, the first question, it depends on the person how much you remember and how much you describe. But the next question is something that you can score easily because the tumor spread is usually a very common question and it has a very common answer. So anytime you get a question about the tumor spread, you have to answer it in 3 ways. Okay. So how you answer it is you have to answer about the hematogenous spread, the lymphatic spread, and the local spread. Okay. And if there is any special mode of spread. So the hematogenous spread here is important because except for the usual arterial spread in renal cell carcinomas, you have something called spreading through the renal vein. Okay. And lymphatic spread, it all depends on the regional lymph nodes. You just have to say it goes to the nearest regional lymph node. That's enough. And local spread, you have to talk about the structure. So in case of the kidney, the surrounding capsule, gerota's fascia, and how it goes outside. And then special modes, usually that is if it has a peritoneal spread. But we know that the kidney is a retroperitoneal organ, no? So we can't talk about seeding to the peritoneal cavity. So here the special mode would be the renal vein mode. Okay. So if you talk about these 4, that means you get most of the marks. And the easiest thing is this is common for almost all of the tumors. Some have one more prominently and the others less, and some don't spread by one mean. So if you just remember that specific thing, the rest you can write. Okay. And the next question. So is there any thing that you'd like to clarify in that? I think the marking scheme has been shared with y'all. So except for the changes and the important points, I won't be stressing on each one of the marks. Okay. If you all want me to do that, just tell me, I'll do that. Okay. So the next question is about testicular masses. So here, whenever you get a question like this, always read the next question. Because testicular mass can pop up from anywhere. But when you're choosing what you're going to write, always look at the next question and see what they're asking. Because you should be able to answer that question from the answer that you write in the first question. Okay. So even if you know about all the tumors, there are a few tumors that we remember very well now. So always remember to write those things. So here, if you pick something like seminoma or teratoma, then we can write a whole lot of bull and get away with it, right? So it's better to choose something like that. So here, if you're going to choose one for a testicular mass, you can usually choose something that is, we know that testicular tumors have 2 origins, right? They can either have a germ cell origin or they can pop up from the surrounding structures of the testis, right? Like your Leydig cell tumors and all those things, and Sertoli cell tumors. But the problem is we don't know much about these. So don't pick something like that. Always pick something that you know about. So germ cell tumors, we know about the seminoma. And teratoma, the easiest thing is it doesn't have a specific structure that is relevant to that tumor. No, it's just a collection of all the mature tissue types or immature tissue types. It has basically components of all 3 germ cell layers, right? Ectoderm, endoderm, and mesoderm. So you can just make up a nice story and write for that. So that's also a good choice. seminoma is a good choice because we have learned about it. It's a potato tumor, remember? It basically looks like a potato, but the difference is usually potatoes are cream, no? But instead of this, it is gray, right? If you remember, but seminomas in the ovary, they are usually cream in color, not gray. So in testes, yeah, they are usually gray. So if you write this, then it's easy. And seminoma, remember that it has less hemorrhage. Okay, hemorrhage is almost non-existent, but there are necrotic patches. Okay, gray, potato-like, less hemorrhage, necrotic patches, and well-defined. When we take the teratoma, that's where this answer scheme is a bit problematic. We have to talk about teratomas having all three dermal layers, right? Endoderm, mesoderm, and ectoderm. But these dermal layers can have mature and immature tissue. That doesn't change according to whether it's prepubertal or postpubertal. Because what the importance of postpubertal and prepubertal is, if we take a teratoma, if it's a prepubertal teratoma, it's more likely to be pure. That means it's a pure teratoma. It doesn't have other components of other germ cell tumors. But if we take a post-pubertal teratoma, it's more likely to be mixed. That means it can have embryonal carcinoma, yolk sac tumor, and other components mixed into it. So these post-pubertal tumors are usually hard to cure. And the other reason why they're hard to cure is these post-pubertal tumors usually have a high risk of spreading to other places. We call it a high risk of malignancy or high risk of metastasis. So those are the two reasons why they're difficult to cure. That's the difference between prepubertal and postpubertal. But both types of teratoma will have immature tissues and mature tissues. The importance is they'll be of all three germ layers. If we take a teratoma that has mature components, it will usually be like a cyst with teeth and skin tissues and epithelial tissues and a bit of cartilage, everything inside it. Okay. But if we take something that has a lot of immature tissue, these immature tissues can't form cysts. So they'll be mostly solid. Okay. So teratomas can be solid or cystic. If they're cystic, they usually have mature components like teeth, sebaceous glands, epithelial tissues, and so on. If they're immature, they're more likely to be solid. Okay. And, so that is basically what we have to talk about seminomas and teratomas. The next question is a very important question. It says, discuss the role of tumor markers in the management of a patient with the testicular tumor. I will point out some mistakes in the answer script here itself. I think you can see the first one. What is that? There are three useful tumor markers. One of the things that most of the lecturers tell us is never start an answer with a number. Don't say there are three things, there are four things. Don't say like that. Because if in the middle of the answer you forget something, the examiner will know that you forgot. Sometimes when they are reading throughout it, they sometimes forget what they read in the first place. So if you haven't said a number, you might be able to get away with the things that you remember. So never name a number at the start of the question. Just say that there are several tumor markers that are important. So I will start with the first one. Okay. The first one that we need to remember when talking about any tumor marker is LDH. That is lactate dehydrogenase. Again, one of the key things is don't call the enzyme LDH, write the full form at least once. That means write lactate dehydrogenase at least once, write LDH in brackets, and then onwards you can use LDH. For anything, that is the rule. So when we take LDH, that is usually there in all cells of the body. Okay. So that is an important indicator of the tumor burden. That means basically how many cells are shed off by the tumor. Okay. So LDH is a good thing for us to stage the tumor. That means if you have a lot of LDH, that means a lot of the tumor cells are being shed. That means you're likely looking at a very large tumor. Okay. So LDH level correlates with the number of malignant cells in the tumor that is being shed. So that is an indicator of the tumor burden. So that is the first thing that you'll need to say. And then we can also use LDH to look at the recurrence of a tumor. That means initially you wiped out a tumor, and then after that you're looking to see whether the tumor is popping up again. You can use LDH to check whether the tumor is there or not. Okay, but it's not that specific. And the other two enzymes that are important is your beta HCG and your alpha fetoprotein. Your beta HCG is a good indicator of choriocarcinoma, and your alpha fetoprotein is one good indicator of yolk sac tumors. So these are important because if you remember the question that we got for the ESA or CAT4, I don't remember exactly, but it was a mixed germ cell tumor. That means it had the components of not only one germ cell tumor but multiple ones. How we used to identify that is by these fellows. The fact that these fellows are there, that means the components of these tumors are also there. Okay. So that is one thing that we can use it for. Again, also we can use these for the to identify the recurrence of a tumor. And this alpha fetoprotein, which is an indicator of a yolk sac tumor, this is usually a very malignant tumor. So if we have this, we can say that the prognosis can be not that good. Okay. So if we talk about those things, that means lactate dehydrogenase, beta HCG, and alpha fetoprotein, and why they are important for diagnosing a tumor, why it's important in the tumor spread, why it's important in the tumor recurrence, and we can also talk about pre-operative and post-operative levels. Okay, because this is something that you'll find in any tumor. Usually, they do something called a pre-operative level. That means where the hormone or tumor marker or level that is there before the tumor is excised. And then they'll do another test that is after the operation to find out if those all tumor cells are removed. If so, then your tumor marker level will drop down drastically. So this is what you will be checking to see whether the tumor marker level has decreased to make sure that you have removed all the tumor. Okay, so preoperative and postoperative tumor marker levels are also important. Okay, the next one is about endometriosis. So one of the things that they usually ask about endometriosis is are these four theories. Why we have four theories is all these four theories can explain one component of endometriosis, but altogether they can't explain everything about endometriosis. That is why we are keeping four theories instead of one, actually. Okay. So the easiest way to remember these is one, we are basically saying that the endometrial tissue had a reflux. Okay. That means it went through the ovarian fallopian tube and it went somewhere in the peritoneal cavity. This can explain peritoneal seeding, but it can't explain it going to lungs and liver and all these ectopic sites. Okay. So that's the drawback. And the other drawback is that it happens in normal females as well, females who don't have endometriosis. So it can't explain it 100% also. And the next two theories is about it going in the bloodstream. Okay, that's how I remember it. That means they are saying that the endometrial tissue, like tumors, can go via the bloodstream and metastasize somewhere, or they can say, or they're saying that there is a progenitor cell that can differentiate into endometrial tissue that is going in the blood, and it will go somewhere and differentiate into endometrial tissue. And there is another theory that says that there is no tissue traveling anywhere, it's just the tissue in one random place differentiating into endometrial tissue. Okay, so those are the four theories. Just remember it like that. One is the reflux theory, and two theories about things traveling in blood, and the other theory is about something randomly differentiating into endometrial tissue. Okay, and the next thing is adenomyosis. Adenomyosis, if you remember what it is, that's more than enough, I think. So, adenomyosis is basically your endometrial tissue getting stuck somewhere in the uterine wall, that means in the myometrium. This can happen prior to C-section or any kind of uterine trauma. How does that happen? That is because something is cutting its way into the endometrium, and when the endometrium is healing, it can go into the myometrium. Okay, that is how I remember it. That's easier, I think. And here, anyway, what will happen is when you have adenomyosis, whenever there is whenever the menstrual cycle starts, this endometrial part will also start bleeding. So what happens when there's a bleeding thing inside your myometrium? When there's a bleed anywhere inside a muscle, just imagine, then it will cause you pain, right? So adenomyosis, the main thing is dysmenorrhea. It can also cause dyspareunia. So there is two things related to pain. And then if you remember that it can also cause increased bleeding. And because there is something here bleeding inside the myometrium, it can also lead to infertility. So if you remember some things like that, then you can just answer. Okay. And the next question is about ovarian tumors. So whenever we have to talk about these ovarian tumors and breast cancers, there's one important thing to remember. All of these tumors are related to the increased lifetime exposure to estrogen. So anything that will increase the exposure to estrogen will increase the risk of these tumors. So taking oral contraceptive pills will increase the risk of tumors. That means, sorry, don't say oral contraceptive pills, but because that is a bit of a conflicting thing. Let's instead just say hormone replacement therapy. Okay. Increase estrogen. So let's say something like hormone replacement therapy. That means your menstrual cycle has ended. Your body has stopped producing estrogen and progesterone, but you're still taking estrogen and progesterone. So that will increase your lifetime risk to estrogen. And the other thing is, imagine a woman who has had multiple pregnancies versus a woman who hasn't had any pregnancy. That means every time that you have a pregnancy, your progesterone levels increase, right? So that means a pregnancy is a chance of reducing your estrogen. So no pregnancy means that time also you've had estrogen. So that will also increase your risk of ovarian carcinoma. So nulliparity will increase your risk of ovarian carcinoma, and then having a reduced number of children will also increase it, and then have you having your first child late in life will also increase it. That means you've had a long exposure to estrogen, and somewhere near your menopause you're having your first child. So that will also increase your lifetime exposure of estrogen. Okay. So anything like that, just think and write. Don't try to remember the exact causes. Just remember that anything that increases the lifetime exposure to estrogen. Okay. So then you can just think of 5 causes like that and write for this question. And then we are talking about benign serous and benign mucinous tumors of the ovary. Okay. So when we take benign serous and benign mucinous, there is something important to remember. So all these, so we know that ovarian tumors, we have three lines, right? Benign, borderline, and malignant. So all of these fellows can be serous or mucinous. So when we take a serous tumor, what will happen is benign ones, serous or mucinous, here they say that in the answer scheme they've given it as multilocular, but actually the benign one is unilocular. The borderline one can be multilocular. So just remember that both are unilocular. So when we take the serous one, in all benign, borderline, and malignant, one of the key features that appear is that it has papillary projections. Okay, even in the benign one, it has, and in mucinous one, there are less papillary projections. And the other thing is the mucinous one has a thick mucinous secretion in it, and the serous one doesn't have that. The serous one has an epithelium that is very similar to fallopian epithelium. Okay. And any borderline tumor, if you have to describe, remember that it can be locally infiltrative, but it does not metastasize. That is why we call it borderline. Okay. So here in mucinous tumors, what happens is the tumor itself, even if the tumor bursts and there is spillage, the malignant cells will not implant themselves anywhere. Okay. But in mucinous tumors, what happens is it's basically like a big balloon hanging from a small stalk. So the risk is this balloon thingy can twist on itself. That means it can have torsion. So if it has torsion, it can rupture. And when it ruptures, this thick, sticky mucus secretion gets everywhere. And it can cause the pelvic organs to adhere to each other. Okay. So they have something called the frozen pelvis. That means all the pelvic organs are stuck to one another. That's the risk of mucinous tumors. Usually these fellows, the benign and the borderline ones, don't tend to metastasize at all. Okay. So they have asked you to compare the benign ones. So the key things will be that the serous ones and the mucinous ones both are unilocular, and then serous ones have papillary projections and fallopian tube-like epithelium. The mucinous ones is macroscopically similar to the serous one, but it has less papillary projections and it has a thick mucus secretion. So if you say that, that's more than enough, I think. Okay. And there is one other thing. Here, they have talked about the serous one as saying the samuma bodies are common in the tips of papillae. If you remember that, just write it. Okay. Okay. And moving on to the next one, HPV. Now, HPV is something that you'll need to remember like a Bible. Why? Because it's one of the most commonly occurring cancers and it is one of the most easily preventable ones with the vaccine. So they will expect you to know about it. So HPV, just remember we have high risk types and low risk types. And the high risk types, that means you're 16, 17, 18, they can incorporate themselves into DNA. That's the most important one. The low risk types, they don't incorporate themselves into DNA. Okay. And here, the high risk ones, they have proteins saying E6, E7, and E5. Here, E5 is not that important for the malignancy of the cancer. E5 is just important in creating the perinuclear halo that is seen in the cells, right? We remember there is something called coeliocytes. So this halo that the coeliocytes have is created by E5. E6 and E7, they are your culprits. So just remember 6 and 3, they are in the same multiplication table. No? So I remember it like that. So TP53 is your tumor suppressor protein, right? So E6 can bind to TP53 and inactivate it. E7 can bind to retinoblastoma gene and inactivate it. So both of these genes are important tumor suppressor genes. TP53 is a tumor suppressor gene, and retinoblastoma, as I can remember, is an oncogene. Okay. So what happens is when you suppress these genes, you end up pushing the cell cycle forward. And what will happen is there will be continued proliferation of the cells, and that won't give enough time for the DNA damages to repair themselves. So it'll end up getting more and more mutations, and it'll end up becoming malignant. Okay. So you have to talk about the high risk types incorporating themselves into the DNA and expressing their proteins E6 and E7, and then those proteins going and blocking out tumor suppressor genes. Okay, so that would be enough for that question. So one of the key things to remember is which protein for which gene. As I said, remember like that. 6 and 3 are in the same multiplication table. So E6 for TP53, E7 for retinoblastoma. And now we are in the next question. So I would like you all to spot the mistake in this answer. I will stress one key point. This is a 28-year-old female. Why is that important? Would anyone like to answer? Okay, so why that's important is that when we take something like sodium valproate, that has an increased risk of teratogenicity. So whenever, even if we diagnose a small child, a female child with epilepsy, and they achieve a very good seizure control with sodium valproate, she can't use that in her pregnancy because it's teratogenic. So we'll have to switch the medication. So whenever we are switching an anti-epileptic, that means we are increasing the chance of that person getting a seizure again. So we don't want to do that. So whenever it's a female, we take care never to start on sodium valproate if she is in her reproductive age or will approach a reproductive age. Okay. If she's like a really old lady who is like 50s, 60s, completely out of the reproductive age, then we can consider sodium valproate. But a young child or a reproductive age female, we won't start sodium valproate. Okay. Unless we have no choice. So better not try sodium valproate for an answer like this. So what we can write instead of that is levetiracetam. Why levetiracetam is that famous is because it's a relatively new drug and it has less side effects. Okay, so using something like levetiracetam, lamotrigine will be more appropriate. So your answer schemes would have given sodium valproate as correct, just mark it as wrong. It's wrong because of this question having a 28-year-old female. So let's go to the next question. Okay, guys. Very sorry. I actually did the questions without knowing that I was logged out of the meeting. So let's go to where we stopped. Okay. If there is an overlap with the recordings, I'm sorry. I'll just start with the third question. Okay. So, third question, we are talking about a 28-year-old female. And here, remember that whenever there's a female, you should never give sodium valproate. That's because of its teratogenicity. So, even if we have a small girl child who's coming with fits for the first time, it's and she achieves a good control of fits with sodium valproate. if she's planning on getting pregnant, we'll have to switch her to another anti-epileptic. So because of that, even for small girl children, we don't start sodium valproate. Okay. So whenever there's a female in reproductive age, better to stay away from sodium valproate unless you don't have any other choice. Let's say that it's not responding to any type, or it's a type that can be controlled only with sodium valproate, then you'll have to give. But otherwise, better to stay away from it. So for this question, the most suitable answers would be levetiracetam and lamotrigine. Okay. So the next question is to explain the mechanisms of action of carbamazepine and lamotrigine and levetiracetam. So here, remember that whenever you're talking about the mechanism of action or the pharmacodynamics, better explain about the disease a bit. So here, say that epilepsy results from the unnatural firing, like overfiring of certain neurons, and to control epilepsy, you need to stop that overfiring. So none of this is not for the question, this is just for knowledge. None of the anti-epileptics can actually stop the seizure from, not seizure, the electrical activity from starting. Okay. So all of your anti-epileptics, what they can do is stop this seizure, that means the electrical activity, from progressing. Okay. It doesn't stop the electrical activity from starting, it stops it from progressing. So how carbamazepine works is it works on the sodium channels. So we have sodium channels and they usually exist in 3 states. So they have these 2 ball kind of things that act as locks, and one they have a closed state. Okay. So this is the side of the cell and this is the outside. So this is the closed state, and then you have an open state where both of these walls are not blocking the entryway. So it can just come inside. And then we have the inactive stage where the in door is open, but the out door is closed. So that means the sodium can't get into the cell. Okay. So what carbamazepine does is whenever these channels open, carbamazepine will come into the neuron and then it will bind to the sodium channel in the inactive state and it will stabilize this inactive state. Okay. So what will happen is carbamazepine will have an action on the faster firing neurons. Why? It relies on the sodium channel to get inside, and more sodium channels will be open in the neurons that are repeatedly firing, right? So more carbamazepine will get in and it stabilizes the inactive stage. That means more neurons will go into the inactive state if they're repeatedly firing, right? Because you go from the active to the inactive, no? So because of that, carbamazepine will have a preferential action on faster firing neurons. So it is effective for seizure activity. And so if you say those things, that is good for carbamazepine. And lamotrigine also has the same mechanism of action as carbamazepine, but the only difference is additionally it has an action on calcium channels too. Just to quickly revise why we are talking about all these things. So when we take a neuron, we know that initially when we take the ganglion ends, you have the impulse coming in and that will depolarize the cell. That means that you'll get your sodium channels opening and then it will travel along the axon, and when it gets to the corner of the axon, it will open the voltage gated calcium channels. And then calcium will come in and that will cause the release of the vesicles. The vesicles will bind with the membrane and release your neurotransmitters, and those neurotransmitters will take it to the next neuron. We know that now. So lamotrigine has 2 mechanisms of action, one on sodium channels and one on calcium channels as well. Sodium channels is similar to carbamazepine. And when we take levetiracetam, that's a bit different. What it will do is, yes, the mic is on, right? That's the next question. Yes. So when we take levetiracetam, what it will do is, usually these vesicles have a protein on them called SV2A. Levetiracetam will bind to SV2A and stop SV2A from connecting with the plasma membrane. So this sp2a connecting with the plasma membrane is needed for the vesicle to fuse with the plasma membrane and release its contents. So when this is blocked, the neurotransmitter release will be inhibited. Okay. So the levetiracetam has a bit of different mechanism of action. Just remember that. And just to talk a bit about sodium valproate, it's not relevant to this question, but it's just in case they ask a question about sodium valproate. So when we were doing the lecture, Shalini Madam specifically told us to remember that sodium valproate had multiple modes of action and it could act on almost all the types of seizures. So sodium valproate acts on sodium channels, calcium channels, and on GABA. So sodium channels and calcium channels are more or less the same as we discussed before. GABA is a bit different. So GABA, you have to know a bit about this pathway. So GABA is from glutamate, and GABA is then degraded. Glutamate to GABA is done by, as I remember, glutamate carboxylase. Just make certain of the name, okay? And GABA is degraded by GABA transaminase. So what your sodium valproate will do is it will increase this glutamate carboxylase activity, and that will increase the concentration of GABA, and it will reduce the activity of the transaminase. So that will reduce the degradation of GABA. So by both of these actions, it will increase the concentration of GABA. Okay. So that's what you need to remember about the mechanism of action. And the other thing is the advice that should be given to this lady if she's planning a second pregnancy. So one thing is, if she's on sodium valproate, if she was on sodium valproate, you need to advise her to change sodium valproate. Okay. And then she won't be able to start the pregnancy unless she has a good control again of her seizures with some medication that is not sodium valproate. But that problem won't be there if we didn't start sodium valproate. So let's imagine we started her on levetiracetam and amotrakine. So now she has good seizure control. We have to talk about adherence to the medication. We have to tell her that this medication won't cause a problem with the pregnancy, but you having a seizure will cause a bigger problem in the pregnancy. So always remember to keep good adherence to the medication. And then talk about antenatal follow-up, that she has to be on antenatal follow-up as well as neurologist follow-up, because sometimes pregnancy will alter the pharmacokinetics of the medication, right? Because it will alter the metabolism and things. So the doses might need to be changed. So she stressed the importance of follow-up as well. And the other thing is folic acid. Because all of these drugs, especially the epileptic drugs, they mess with the neuronal system. It can also affect the neurodevelopment of the baby. So taking enough folic acid is very important. Okay. So next one we have to go into is Parkinsonism. So Parkinsonism, in this question, we have to talk about levodopa and carbidopa and Parkinsonism. So here, just take one or two lines to briefly explain what happens in Parkinsonism, where you lose the pigmented neurons. That means dopaminergic neurons in your brain. So that will cause the reduction of dopamine. And then talk about why we can't give dopamine directly. That's because the GIT system will degrade the dopamine and it won't get absorbed. So we are giving levodopa, which can be absorbed and it can also penetrate the blood-brain barrier. So here, after it crosses the blood-brain barrier, it will get converted into dopamine by dopa decarboxylase. So what will happen is this dopa decarboxylase is also there in peripheral tissues. So sometimes levodopa can get converted into dopamine outside. So that will reduce the concentration of levodopa going to the brain, and it will also increase adverse effects, because adverse effects such as flushing and things like that, they come from this peripheral dopa. So that is why we are giving carbidopa. which is a peripheral decarboxylase blocker. So we are stopping the conversion of peripheral levodopa to dopamine. So more levodopa will cross the blood-brain barrier. So that will reduce the dose that is needed. And the other thing is, it will also reduce the adverse effects. So because of all these reasons, we are choosing carbidopa and levodopa combination. And the other thing that they have talked about is in the next question, selegiline. So when we are talking about drugs for Parkinsonism, we had levodopa, dopamine receptor agonists, MAO-B inhibitors, COMT inhibitors, NMDA receptor blockers, and antimuscarinic drugs. Out of these, antimuscarinic drugs are usually for conditions that are drug-induced, like drug-induced Parkinsonism. The other fellows, you can use them for Parkinsonism without a cause. So here, when we take dopamine agonists and MAO-B inhibitors, what they basically do is they either increase the dopamine concentration or act like dopamine. So when we take levodopa, though it is the definitive treatment for Parkinsonism, that can only be given for a selected number of years. Okay, that's because after that, patients develop tolerance to this medication and it doesn't work for them. So because of that, we reserve levodopa to the very end and we try to make do with other things beforehand. So this MAO-B inhibitors is one of them. Okay, so what they do is dopamine is degraded by monoamine oxidase, and the version of that in the brain is called MAO-B. So if we block this MAO-B, then the dopamine that is naturally released will remain in the brain for longer. So that means the action will be there for longer. So that is the benefit in giving it initially, right? It will stop the need for levodopa until a very late stage. So we can work with MAO-B monotherapy early on. But the benefit of giving with levodopa is to stop something called end-dose dyskinesia. For this, just remember a small story. So what happens is, whenever we give levodopa, it becomes dopamine and some of it does the job that is required at that moment. The excess goes into the dopaminergic neurons and gets stored. And every time the concentration starts dropping, this store is released from the dopaminergic neurons and that reduces the fluctuation. But as these dopaminergic neurons are destroyed, there's nobody who is storing the dopamine. So once the effect of the dose wears off, there is no store to be released. So there will be huge fluctuations in the dopamine level. So towards the end of a dose, you will find this person again starting to freeze up very quickly. So that we call end-dose dyskinesia. So what MAO-B will do is it will stop this dopamine from degrading. So it will help the dopamine remain until the next dose comes. So it will stop end-dose dyskinesia. Okay, just remember that. That is why we are giving selegiline. So you don't need to remember exactly what happens. Just remember that it helps with end-dose dyskinesia and it also has a levodopa sparing effect where you can give it before starting levodopa. And then the last two things that we have to talk about is Loeffler syndrome and typhoid. So what we need to know about Loeffler syndrome is basically the life cycle of Ascaris. So here, remember that Ascaris, what it does is it comes through the fecal-oral route. You basically ingest the eggs, and once it becomes a larva, it migrates to the lungs and it undergoes a molding stage. Like the caterpillar becoming a butterfly. So it undergoes a molding stage, and there it has its body parts being shed off. So that those are antigens, and those antigens trigger a hypersensitivity response, and that causes wheezing-like manifestations in the pulmonary arrangement. So wheezing like things like this, like bronchoconstriction, increased bronchial secretion, and things like that. So when they ask about low FL syndrome, just describe that. The next question is about malnutrition. Okay, so here when we talk about malnutrition with ascaris, there are two big things to remember. So initially, it will do that by reducing your appetite and reducing your absorption. So when we take the absorption part, appetite we can just explain. No, it's like anorexia. You don't eat, so because of that, you don't have enough nutrients. Absorption part we had to explain it in multiple ways. So we know when we take the gastric lumen, there you have your villi, microvilli, and then your lumen. So the worm just being there will reduce the number of microvilli. No? The worm is occupying the place of microvilli. So because of that, the surface area will decrease and that will also decrease absorption. The other thing is it will be damaging the villi and microvilli. That will also reduce absorption. And the other thing is these parasites will be competing for nutrients. That will also reduce absorption. And it can also secrete enzymes that stops protein degeneration. It does that to stop itself from being degenerated. Okay, so it will stop enzymes like trypsin and chymotrypsin. So that will again reduce absorption, and it can also block the lactase enzyme. So that will reduce the absorption of lactate, and it can also interfere with the absorption of other vitamins and fat soluble things and stuff like that. Just remember those main mechanisms and then you'll be okay. And three high risk groups which are likely, that is basically general knowledge, that you just have to talk about people who have a high risk of fecal oral infections. Anybody, that means anybody who has a risk of consuming soil that is contaminated with feces. So little children playing in sandboxes and then washing, not washing vegetables and taking them for salads, and not boiling vegetables and meat properly and things like that. Imagine and write. The next thing is source and mode of transmission of typhoid fever. Sorry, enteric fever. Typhoid. No? So just remember the story of typhoid Mary. So she's the lady who cooked, and everywhere she cooked, she gave people typhoid. That's because she was a chronic carrier. That means your salmonella typhi, and paratyphi, it basically exists in the GI tract, then it goes into the gallbladder, and every time it can get shed with the bile secretion. So because of that, even if the person is asymptomatic, they can still be shedding. And so humans are both patients and chronic carriers. So source and mode of transmission, so it will be humans, and mode of transmission is fecal oral. That means the salmonella will contaminate the feces and it will go into the water sources and food sources, and it will go to the next person. Prevention and control, basically you need to stop the fecal oral transmission. You need to treat the people who diagnose and treat the people, and then you need to make sure that you wash your hands before and after toilet and before and after eating your meals, and then um, properly properly wash your cooking utensils, etc., etc. Okay. So, do you guys have any problem or question with what we discussed up to now? Problems with the mark distribution or things that you didn't understand, confused, anything? I think that is it, Twaragesh. Yes, dude, yes. Okay. That's all right, dude. I didn't see it that time. That's why. Okay.